So yesterday we talked about nomenclature for degenerative disc disease. Let me see. Okay, good. Shiv is joining us. Hi, Shiv.
Good afternoon.
Good. So we're going to pick up where we left off yesterday. We talked about nomenclature for degenerative disc disease yesterday. So now we'd like to talk about some of the degenerative changes in the spine which can produce back pain, which are not contour abnormalities of the discs. So that includes spondylolisthesis, overall degenerative changes and desiccation of the disc, changes in the end plates of the vertebral bodies. The HIZ, we'll talk a little bit more about high intensity zones, but we've already covered that, and facet arthropathy. So spondylolisthesis is defined as greater than a 1 millimeter displacement anteriorly or posteriorly of the cortex of one vertebral body with respect to the other. Generally, if it's 1 millimeter, I don't always comment on it. The bottom line is spondylolisthesis are usually due in the lumbar spine to one of two things, and you have to say which one it's due to. Most commonly, it's due to degenerative disease of the facet joints, especially in people whose the planes of their facet joints are really more in the sagittal plane rather than the coronal plane.
John?
Yes.
You say that you don't mention spondylolisthesis less than 1 millimeter.
Right.
If you have basically a fracture of spondylolisthesis type, I'm not sure that you should not mention it. I think maybe you should.
Well, just the definition in the literature is that it has to be greater than 1 millimeter. Obviously, there's a fracture. You've got to comment on the fracture and any potential displacement of the fracture.
Well, the thing is, stress fractures in kids are quite common that produce spondylolisthesis. And they start out with 1 millimeter, but they wind up with a lot wider than that as time goes on. That's why we put them in casts, braces, etc. So I don't want to contradict you, but I think if I see it, I would tell it.
Okay. And then the second cause of spondylolisthesis is, as John referred to, fractures of the pars interarticularis. So we'll talk about those in greater detail later. Now, as far as the degenerative changes of the discs, which do not have to do with contours, there are several grading systems basically similar to this. This is the Firman, which is 2001. It was kind of based upon an earlier one that we discussed a day or two ago, which was from about a decade earlier, which just shows signal changes within the nucleus pulposus of the disc. I find that this grading, there's a lot of, it's hard, especially in the middle here, to uniquely place each disc in a grade 2 or 3. I don't think the grading of the disc really affects management. This is more for research purposes and for following people longitudinally. But if you want, there is a grading system where you can grade the signal changes within the nucleus pulposus. And then there are the Modic changes from this paper in Radiology. Jeff Ross was his fellow at the time who basically came up with it, and then they published it together in Radiology. And here, when we see the end plates next to the disc, type 1 changes are where you see edematous changes within the end plate. Type 2 is where that edema goes away and you end up with fat replacement of the marrow space. And then finally, with chronic changes, you get the bone tries to heal itself, as we've talked about repetitively in these lectures over this year. You get thickening of the trabecular bone, which leads to replacement of the fat with calcium within the thickened trabecular bone, and we call it sclerotic changes there. So this is really early injury to the end plates. This is in the healing phase where you no longer have a good milieu for hematopoietic marrow, and the hematopoietic marrow is replaced by fat, and then finally the sclerotic changes. And then we talk...
John?
Yes.
I hate to interrupt again. The Modic changes don't really correlate all that well, do they, with pathology
Well,
in terms of time?
this is the progression of changes over time, and it usually takes somewhere around 6 months to a year to go from 1 to 2, and then probably several years to go from 2 to 3. But that is the temporal progression that we see all the time in these end-plate changes, yes. As far as associated with symptoms, again, it's very hard to state where patients' symptoms come from in the lumbar spine. And all of these changes have been seen in people who have back pain. So it's hard to know where the actual symptoms are coming from.
But the changes don't always correlate in terms of Modic changes. Like Modic 2 may be a Modic 1 or Modic 3 in terms of time, talking about age of people.
My experience over time, and most of the literature is that it starts with a 1, progresses to a 2, and then ends up with a 3.
Always?
Well, I wouldn't say always, but I don't think it would be possible to go from I don't think it'd be possible to go from 3 to a 1 or 2. And certainly if you have repeat trauma, you can get edema within the fat.
What I mean is stay the same, like Modic 1, and then it looks like Modic 2, and just stays like that. Is that because I've gone to conferences where they're talking about that, and they say they don't depend on the Modic changes.
They don't have to progress. And again, you don't change treatment based upon a Modic change. It's really an indication of what's happening within the spine. But it almost certainly starts out as trabecular injury of the end plates, which is the Modic 1, leads to a healing where you get the fatty change, and then eventually it ends up with sclerotic changes at the end stage of the degenerative process.
Ditto.
Okay. And then the high intensity zones we've talked about, and then finally facet osteoarthritis. And this, along with atrophy of the muscles and ligaments, are probably the most actual common cause of pain within the spine. And you can characterize them. This is a paper from Carino. I think this was back when he was at Hopkins. And this just shows that you can grade them into normal, mild, moderate, or severe, but then there's a big overlap between them. And you're all familiar with what they look like, and we'll see some in a minute. When you look at all of these non-degenerative changes together, in this paper from Carino, who's now at Special Surgery, there's only moderate agreement among experts. So you can look at all of these changes, and between two different people, you're going to have a lot of variation in what they call it. So the reproducibility is intra-observer and inter-observer is not perfect, but these aren't terrible numbers in the imaging world either.
You take 10 radiologists and you're going to get 10 different opinions.
Well, hopefully there'll be some correlation between them.
Hopefully.
So here's a question from a paper in Skeletal Radiology. Do worse MRI degenerative findings correlate with disability and low back pain? And basic. So what they did was create a 5-point system where they graded Modic changes 0 to 2, with 0, 1, and 2 being the different Modic changes, whether you have a high intensity zone, whether the nuclear signal is normal or abnormal, and whether you've got loss of disc height. And then they took standard outcome measurements from lumbar spine scoring systems, and they found that there was no correlation between symptoms and disability and the low back and degenerative findings as scored on that scoring system. And we talked about spondylolisthesis. Here we can see the displacement of 4 on 5 here in this particular case, flexion, neutral, and extension. There was no motion. And generally we found that it was very rare for them to be motion at these joints, especially in older individuals when you have spinal.
Well, what I like to hear a radiologist put in a report, spondylolisthesis, degenerative disease. Spondylolisthesis, for most of us dummy orthopedic surgeons, spondylolisthesis means that is a kid with a problem of a fracture developed by activity. Spondylolisthesis degenerative type, that's adults.
Yeah, John, we're only talking about degenerative disease in this lecture.
Okay, I'm sorry to interrupt. I forgot about that part.
Yeah, this is just degenerative disease. The spondylolisthesis in kids will be in a different lecture. That'll be under trauma.
I understand. But what I think when you're dictating a report, the fellows and you also, I think you should mention that it is not a spondylolisthesis of a real type that we usually use the word.
Yeah, well,
I would say I usually say listhesis, anterior.
Okay.
That kind of says it.
Okay. Yeah, it's important to say what's causing the listhesis, and it's
right.
Either facet degenerative disease or pars fractures. So you have to state those two. In kids, you don't really see the degenerative facet disease, so it's almost always a pars fracture. And adult, it can be either, though the older the individual, the more likely it's going to be facet disease. And then here's another example where it's also associated with degenerative disease of the disc at that level, which is also quite common.
But if you look at the facets, you don't really see a problem, do you, John? Other than maybe a little degenerative change.
In what case are you talking about, John?
The one that you had before.
We don't see it. That's not the right location to see the facet disease.
Okay, that's why I don't see it.
I was just showing the slippage there. Okay, here's another case where we can see an anterior displacement of 5/1, and then if we go off to the side here, we can actually see that there's a pars defect. So I like to look at pars defects both in the sagittal as well as the axial planes. And with CT, they're very easy to see. With MR, especially if you have a lot of degenerative disease, sometimes the pars fracture can be a little bit difficult to see. I'll show more examples in a minute. On the axial images, you kind of see what looks like two facet joints. On the sagittal images, you see an interruption of the pars, which should go all the way up here.
But this is a degenerative change, and ergo also has a pars defect. So that's what I said. I was trying to say that when you do a report, either include the pars or disclude the pars injury or whatever that may be.
Yeah, you have to. You have to say whether it's due to the pars defect or facet disease. And
right.
If it's a pars defect, then it's primarily going to be due to the pars defect generally. Right.
Thank you.
Yeah. And then here's an example. Let's see. Here, Sarah, what do you think of this case?
Chronic back pain with left-sided radiculopathy. So we have kind of like a moderate enterolisthesis of L5/S1, and a lot of disc disease at L5/S1, near complete loss of disc height, and
so the other thing you need to look for when you have spondylolisthesis is do you have any nerve root compression?
Okay, I don't see anything definite. I'm not sure.
So
I'd like to look at the axial.
Right here.
Okay.
And one thing to remember at the L5/S1 level is that when you get spondylolisthesis, sometimes you can get compression of the exiting 5 root due to the iliolumbar ligament, which becomes stretched and can come down and compress the nerve root. So you need to look for that at that level. And then here we can also see that there's bony narrowing of the five foramen. So this patient has compression of the nerve root, both due to bony compression as well as iliolumbar involvement as well. And that's called iliolumbar entrapment. Okay.
My daughter has that.
Oh. So, yeah, Sam, what do you think of this case?
Development of spondylolisthesis.
And I just broke a HIPAA rule.
Just say that she gave you permission.
It looks like there's minimal retrolisthesis of L5 on S1. Some on the MR especially. Yeah. On the radiograph, I wonder if the facet is perched actually for L4-5. L4-5 facet looks. I don't know. It's just not. I don't know. It just doesn't seem to be articulating in the cervical spine. Usually we'd see that.
Facet perched?
Yeah. I don't know. I don't see it. I just don't see it articulating normally.
I wouldn't comment on it if you don't see it.
I don't see a normal articulation there. But okay. Anyways, so aside from.
So this is on 12396. Mm-hmm. Here are the axial images. What do you see here?
Not a lot. There's maybe minimal degenerative change.
Yeah, pretty minimal. A little bit of fluid in the facet joints here.
Yeah.
Okay. This is on 5/7/2002. And a little bit more degenerative disc disease. And the other facets aren't too bad.
Yeah.
And this is 2105.
Okay.
And then if we go up to 5/8/07, this is what we see.
Well, this looks like Modic 2. Some fat replacing the marrow here. A little bit more facet degenerative changes.
I don't understand. This just looks like it's developing changes. Forget that one. Let's go to the next one. Go back and see why that's in here. Okay, so here's an example where we can see the spondylolisthesis here. You know, with plain films, you grade it as grades 1, 2, 3, and 4. With MR, I just like to give the actual measurement there. Now, the important thing when you, if you can, you always need to think in your mind when you do a lumbar study, how do you number the different levels? So this looks like maybe a 5, 4, 3, 2, 1. But if you have that one, then the conus is way up here around T11, which should make you very suspicious as to the proper numbering system.
So I'm thinking 5. That.
Yeah. So you really then, if it looks at all suspicious, you need to go up and find the lowest rib. And so if you find the lowest rib, then you count down from there, you'll find that what I was calling L5 is actually a transitional S1 at this level. And then if you look up at 5.1, we can see on the sagittal images there are spondylolytic defects, and on the axial images we can see bilateral spondylolysis here. And so if we go back again, this is the transitional vertebral body, which is actually a S1. This is 5, 4, 3, 2, 1, and this is the lowest level that actually has a rib. So this would be T12, and then it looks like the conus is at the normal position in which we typically see it. But as I showed in that case before, if you see anything that looks suspicious, you really have to take the effort to make sure that the numbering is correct. Because one of the most common significant errors I've seen in lumbar imaging is not numbering the levels appropriately. And like that case we saw before, you can operate at the wrong level which can be a problem. So it's worthwhile going over that, and the act can be helpful.
So, John,
Yes.
is the L5 the listhesis vertebra?
Yeah.
That right there.
This is 5. This is S1. So in a case like this, I say that the lowest complete disc is assumed to be the S1-2 level, and T12 has the lowest vertebral body, and therefore the spondylolisthesis is the L5-S1 level, or L5 additional vertebral body.
Oh, okay. I sure would like to see an X-ray on this.
Yeah, well, a lot of times we don't have X-rays, so we have to take it off the MR. Okay, and that just shows, and spondylolisthesis. And then here we can see an almost complete spondylolisthesis at this level. And these large ones like this are almost always due to bilateral pars defects or old fractures. Okay. Let's see. Hamid, what do you think of this one?
Okay, so middle-aged male with back pain radiating to left lower extremity. Okay, so endplate changes at L3, L4, and some disc signal loss at L4, L3, L4, 5. Yeah, and there may be some one transitional vertebra there.
Okay, so there's a lot of disc disease here, but what about the vessels over here?
It's a spar, bony spar, and
yeah, let's go to the axial images. What do you see here in the axial images here?
What is that? Is it some vessel or something? Oh, okay.
Okay.
Coming, okay, Math-Turner syndrome.
Yeah. So the vein is coming underneath the artery and is being compressed, and that can also, that's a very rare cause of pain as well. So be aware of some of the variants that can occur in the vessels in this area, which may need to be described. So this.
Okay.
This disease.
Wow.
I mean, the patient had degenerative disease, but that had nothing to do with the May-Thurner syndrome. This is an aberrant left common iliac vein, which is between that goes posterior to the iliac artery, and it can be associated with DVT, and it can also be cause of some pain. And it can be worsened if you have spurs or disc disease at that level.
Okay.
Okay. Shiv, what do you think of this case?
58-year-old man with new onset low back pain. So it looks like there's hypertrophic facet arthropathy, and there's a big aortic aneurysm, maybe it looks like.
Yeah, there you go in the sagittal images.
Yeah.
And if you look at the scout view, you can see it's probably a markedly thickened wall. You've got the flow here, slow flow enterally, maybe even some clot. But anyway, this is a abdominal aortic aneurysm. So, don't forget the retroperitoneum. So when I do lumbar spine, my last paragraph is always on the retroperitoneum. And so you can see aneurysms, you can see other variations of the anatomy of the vessels. You see another common thing that can be missed with back pain would be stones in the ureters, hydronephrosis, kidney disease. So all those things really need to be evaluated. Okay.
Ureters.
What about the ureters, John?
Ureters.
What about them?
What I was going to say is calcium deposits in the ureters can cause quite a bit of back pain.
Right.
A lot of people, that's their main pain is the back.
Right. So what happens here with? What about all these findings that we see on MR of the lumbar spine? Well, it turns out that disc protrusions are common in patients without symptoms, And if you actually just look at MR scans with and without disc protrusions and patients with and without pain, there is no statistical association between disc protrusions and pain. So, and these are 5 papers that all basically say the same thing. So another question is, what MRI findings correlate with prognosis in patients with low back pain and sciatica? Talked a little bit about this. This is actually some papers by Mike Modic in his early days. He looked at herniation type, all the ones we've described, size, location, and changes over time, and none of them correlate with actual back pain and sciatica prognosis. And those kind of 2 papers from Mike Modic in Radiology. What findings correlate with prognosis in patients with low back pain? Well, the only statistical correlation that he found was if you had the presence of a focal disc protrusion, called a herniation in this report. It's a positive prognostic finding, as acute herniations of the nucleus pulposus all get better. And we talked about that before. Now, what lifestyle factors are risk for hospitalization for sciatica? Smoking increased the risk of being hospitalized for sciatica by 33%, obesity by 36%. Obesity, primarily measured by waist circumference, is a 41% risk factor, and walking or cycling reduces the risk by 33%. So it's one of the, again, another reasons why I like to comment upon the amount of subcutaneous fat, because it's highly associated with risk for being hospitalized for disc disease.
The Swiss are more excited about weight than smoking. I don't know why.
Yep. MRI findings. Also, this was a study where they did MRI in asymptomatic young tennis players. So the question has often been, if you have a young patient that comes in, you get an MR scan and it shows abnormalities, then a lot of people say, well, they should have normal MRs, and therefore the abnormality has to be due to some a recent trauma. And if you look at these players who are asymptomatic, only 4% had a normal MR. So changes in the lumbar spine occur very young, in the early teens, especially in athletes. Facet arthropathy, they saw in 90% of these young tennis players. Synovial cysts in 22%, disc degeneration in 62%, herniations in 31%, pars injuries in 30%, and grade 1 spondylolisthesis in 5%. All of these patients had no symptoms of back pain, or at least none that they described at that time. So these changes are very common, and therefore, when you interpret MR scans of the lumbar spines, you've got to have a high degree of skepticism concerning the clinical significance of a lot of the findings. And it's very clear, and I think I'll come to those papers in a minute, that the one thing that MR has done to the lumbar spine is greatly increased the rate of surgery in the United States, and therefore greatly increased the cost. And the cost of MR is insignificant. The costs are all generated by the surgeries that's done. So now, what MRI findings are seen in patients with new onset serious low back pain? This is another study by Carnegie. We already talked about one of his studies, which was the one that actually showed that you damage the discs when you do a discogram. This is another great study that he did, and it's published in the Spine Journal. They took 200 asymptomatic patients and they did an MR scan on those 200 patients. And then they followed them for over 5 years. What they found is that 49 of these 200 patients, so that's about 25%, developed a new episode of serious back pain. But of those 49, the MR scan was identical before and after they developed back pain. So of these patients, now it turns out that 51 of these patients, so a little over 25%, developed new episodes of back pain. But of those who developed new episodes of serious back pain, the 98% of them had no change on their MRIs. So the cause of the back pain is not something that you could see on an MRI examination. 2% or 2 patients or 4% of the patients who became symptomatic showed new MRI findings, and both of them were nerve compression with radiculopathy due to new disc protrusions in the foraminal zone. So we talked about before how important it is to see the location of the focal protrusion, and foraminal zone protrusions are more likely to be symptomatic than others. And there's not a lot of patients, so you can't say this is overwhelming evidence, but it's certainly very suggestive evidence that those may be symptomatic. So the conclusion from this is that most MRI findings are not associated with the cause of back pain, except for acute foraminal protrusions. Risk for serious low back pain is not increased by minor trauma. A lot of these patients also had minor trauma, and that was not associated with a lot of new back pain statistically. Now, this paper and many other papers have shown this. Serious back pain is associated with the following. The setting of chronic back pain, so if you have chronic back pain, you're more likely to get a serious acute new back pain, abnormal psychometric profiles, smoking, and disputed compensation claims. So those are the major risk factors for the development of new severe low back pain. What new MRI findings correlate with new onset low back pain and radiculopathy? Now, this is a separate study and published in the British Journal. And what they found, they looked at 123 patients without symptoms who obtained MRI. They followed them for every 4 months for 3 years. And after 3 years, they found that 8% obtained new MRIs with new findings. So not too dissimilar from Carrigy studies. What they found is 20% developed new low back pain, and 57% of patients developed new radiculopathy. They said new but not old annular fissures were associated with new back pain. So this is one of the few papers that actually shows that annular fissures may be associated with back pain. This and that. There's that other one from Korea, but most of the fissures were old, and it's only new ones, the newly acquired ones, and that makes some sense. If these annular fissures start out as annular tears, and then you get granulation tissues and they become stable degenerative change over time, it's not it's reasonable to suggest it's only the new acute tears that actually would cause pain. And also new but not old disc extrusions and root impingement were associated with new radiculopathy, which would go along with Carrigy's study. And new symptoms were rarely associated with new MRI findings. So very similar findings to what Carrigy's study showed. So then there was a time a few years ago, and we're just now coming back to this right now, if the morphology and the old MR techniques did not show any good correlation with back pain, then are there other things that we can look at? And one thing that we looked at a number of years ago was using MR spectroscopy to measure lactate and other metabolites in discs. And we worked closely with this. We even put a 3T Siemens MR scanner out in east of LA in a site to work with an orthopedic surgery group to get data to see whether we can measure the lactate, the amount of lactate in a disc by using MR spectroscopy. And there was data initially that showed that the lactate level did correlate pretty highly with discs that were associated with positive discograms. And now there have been more studies in Europe using this technique. And so right now the company that was working on this just got additional funding, and they're starting to do larger clinical trials in the US right now. And we're starting to work with them again in Southern California. Other people looked at T1 row measurements. They estimate the glucosaminoglycans concentrations within the disc. Some people have used sodium imaging, which is difficult and not something that we're interested in doing. It requires a lot of non-standard hardware to do that. It's another way of estimating GAG. And then some people have used different tracers to look at diffusion within the disc, and even diffusion weighted imaging to look at it. And the bottom line is there is some data to suggest that increased lactate levels are more likely to be associated with symptomatic discs. On the other hand, the problem with these studies is if you actually develop a technique that shows that that disc is a cause of pain, the question is, what do you do about it? It's not at all clear to me that operating at that level, which is what the surgeons associated with this think you should do, is the right way to go forward. And you'd have to have studies to really see whether the surgical risks are really worth the benefits of that. So if we could show in larger studies that measuring lactate and other metabolite levels are associated with pain, maybe we could think of non-invasive ways to try to treat that, and we would understand the pathophysiology better. But to go from that to doing surgery, I think, is a big leap.
Pain is not a reason to do surgery unless it's excruciating and you ruled out with an MMPI some other causes of symptoms. I never operated on somebody just for pain.
Okay.
I gave up surgery of the back after about 8, 10, maybe 10 years of practice. The reason being is I was too dumb to figure out who's going to get well or who's not going to do well. And I worked with a neurosurgeon who did the laminectomy and now would do diffusion if necessary. And we never could figure out more than maybe 70% of the time who's going to get well. It's a very sad situation when you're dealing with a situation like that. And it's not a minor operation. That's what happened to my surgery of the back. I gave up.
Okay. All right, Thomas, what do you think of this case?
Left-sided sciatica. So there's a cystic lesion adjacent to the sciatic nerve, by compressing on it.
Yeah. And then you can see that this may have a communication with the joint space if you follow it all the way back again. So what would you call this?
It's a ganglion, I guess, from the hip joint.
Yeah, I think there's a posterior labral tear here, and this is a paralabral cyst which is extending out and compressing the sciatic nerve. So when there is sciatic and it's really significant, you really kind of have to follow the sciatic nerve along its course. We'll talk later about the piriformis syndrome, and I still have a lot of questions about what that really is, but we'll talk about what it's supposed to be in later lectures. So the concept of disc surgery is if you have a disc herniation here and it's compressing upon the nerve root, that you go in and you remove the disc herniation, the nucleus pulposus here, and hope that you get healing of the annular fibers there, no longer have a disc protrusion which is compressing the nerve root. So this is a 36-year-old male with back pain.
Okay, we have facet arthropathy more prominent on the left side. Yeah. And it's a significant disc
I just want you
protrusion.
to look at the
Muscles.
the muscles back here.
Yeah, there's atrophy.
There's a little bit of atrophy. Actually, for an American, this isn't that much
Normal.
atrophy. We see a lot of fat here, but we have relative symmetry of the spiny erecti muscles. So they decided to have surgery, and there's thought that his back pain may be due to a disc problem. So they had surgery, and then this.
I'm sorry, John. Surgery for what?
For back pain.
Good luck.
To do that. But despite the general recommendations, even today, it's a common occurrence.
I know. Unfortunately.
So this is 9809. The patient had surgery, and they came back with persistent symptoms, and this is a MR scan about a year later.
Okay, so now there's increased signal within the right paraspinal muscles. We have some myositis on the right side.
Yeah, this was about 6 weeks after the surgery.
Okay.
And this is actually acute denervation. Now, spinal muscle denervation, it can be due to degenerative spine disease, they say, though I'm not sure I've ever really seen that proven. Certainly perioperative damage, which we'll see now. A perioperative fibrosis can envelop the nerve and cause nerve dysfunction. And it generally presents with muscle weakness, with or without pain, and often radiculopathy. And
one of the things that some surgeons do is they pull the paraspinal muscles too far laterally. You should try to keep the muscles as close to the posterior spinous processes as possible, and not really put a lot of pull on it with the retractors. So we have some orthopods that are gorillas, and you can do a lot of damage, not just the muscles but the nerves too, as you can see on these findings.
Yeah. And so the major muscle here is the multifidus muscle, and you can see where it goes to the different segments, and as we talked about before, is very responsible for maintaining proper orientation of the different spine segments during activity. And there are a number of back pain syndromes associated with this. You can see that increased fat, either on MRI or MRS, the multifidus muscles are associated with back pain. You can see a decreased cross-section area on a CT scan is associated with back pain. And then also decreased strength, endurance, and excess fatigability can occur when you get atrophy of this particular muscle, as can be seen on EMG studies. And the issue then, as far as loss of the strength of the multifidus muscle, is it disuse versus denervation. Most of what we see in the non-operative patients is disuse from what we talked about before. The other thing to remember is that the primary nerve that innervates the multifidus muscle actually comes out of L3 and then innervates the muscle all the way down here. So if you do something at the level of 3 or below, you can affect this nerve and cause dysfunction distally, which can lead to muscle atrophy or acute denervation like we saw on that last case. And it's very common after surgery to see fatty atrophy of one side, almost always on the side of the surgery. This was a laminectomy defect here. This would be the more normal atrophic muscle on the opposite side, but you can see much more fat replacement and the muscles on the same side as the surgery. Obviously, when this occurs, then you no longer have the same ability to control the segments of the spine as you did when the muscles were normal. And here we can see extensive loss of the muscle on that side, and this is all focal postoperative atrophy. This now with a lot of more minimally invasive techniques for doing the surgery, denervation of the spinae erecti muscles is less commonly seen than in the past, but it's still commonly seen. But 15 years ago, almost all patients who had spine surgery ended up with denervation of the spinae erecti muscles, and it was rarely commented on in radiology reports. I'm bringing this up because I think you should always, in an MR report of the lumbar spine, comment on the integrity of the spinae erecti muscles, even to say they're normal, which isn't very often in the U.S. population. Okay.
29-year-old low back pain radiating down left leg. Looks like there's some disc desiccation, disc height narrowing at L5S1. Maybe a high intensity zone. Not too shabby. There's a little bit of maybe extrusion centrally.
So this was called a disc herniations at these two levels.
Yeah.
This was called a disc herniation, and they said it was 5 millimeters and extending over.
I don't think that's extrusion.
Yeah, no, you're right. It's pretty broad base going into the left foramen.
Yeah, I'm saying that was in the report. Okay, this is on 10/15/04. So you can see there's maybe a little bit going there, but notice it's not really affecting the nerve root. And notice the spinae erecti muscles. What do you think of them?
There's a little bit of fatty atrophy, I think.
A little bit, yeah, but
not too bad.
Okay, so this patient, a few years later, went on to surgery, and 6 years later, this is what the MR scan looked like.
So there's disc spacers, and there's some scarring over the spine posteriorly, and yeah.
This is what the axial images look like.
I mean, there's plenty of scarring.
I don't know if I told you, but USC sent disc spacers on the shuttle.
Okay.
And the results that they came back with were not published, as far as I know.
Okay.
So I can't tell you anything about it.
Okay.
But they did send up there to see how bone heals in astronauts.
Okay.
Or will heal when they go to Mars or whatever.
Okay.
Anyway, sorry to interrupt, John. This kind of treatment was Cloward came up pretty much with this idea, and then he was without insurance and couldn't do surgery anymore in Hawaii.
This is at 5/1. This is at 4/5.
So there's like no muscle bulk, I guess, at all. It's all scar, I guess, right in the middle.
Yeah, it's probably all scar, and you can see there's really complete fat replacement of the muscle. So again, this patient's really not able to control the spine anymore. So you can see why, if you actually destroy the innervation of the muscles and you no longer can control, and notice this is going way up here where you have loss of the normal muscles, you can see why you very commonly will get progressive degenerative disease and instability going up from the surgery site, because this is fused, but you no longer can really control the muscles the spine by muscles. So however, all the spine control is from the ligaments in the annula, which become stretched and torn, and you get degenerative change and displacement. Okay.
The diagnosis for this case is SAD.
Okay. All right. Hassan, what do you think of this case?
Okay, so 40 years old female with pain radiating to both legs for 3 months. So seems like there is a large disc foraminal extrusion, L5S1, compressing the nerve. Yeah. So, yep, right, foraminal extrusion.
Okay, this was on
extrusion, whatever.
3/27/09, and this is now 10/5/09. The patient has increasing pain.
Okay, so probably they did some surgery in between.
Okay.
And lots of fibrosis there, scar tissue, pulling the nerve probably. Yeah, lots of post-surgical stuff there, muscle atrophy, scarring, fibrosis.
Right.
Yep.
And so this is post-operative scar.
Mm-hmm.
And so
the pathology is bilateral in terms of symptoms. Why would they only go on one side?
oh, well, the disc extrusion was only on this one side.
I don't know. Okay.
There's nothing they could operate on the other side, John. So anyway, so they went on this side. They removed the disc extrusion, and then we can see the scar tissue that's developed here. Now, with a lot of current techniques, we tend not to get this kind of scar tissue. This used to be common 10, 15 years ago. A lot of people like to give contrast. This is a T1 weighted pre and post contrast, and you can see this kind of diffuse enhancement as we were talking about. And the concept was that if you have scar here, you can't reoperate here. Surgery only makes the scar worse. But a lot of studies have shown that if you have scars surrounding a nerve and it infiltrates in the nerve, it can actually extend into the nerve, retract, and then you can get a lot of nerve dysfunction due to the scar tissue. So this is post-operative scarring after surgery. The patient just suffers. But that was the feeling at that time. Now, since then, people have done studies looking prospectively at patients who do and do not develop scar. And this is one for the New England Journal in 2013, and they actually found that whether or not you have scar did not differentiate people's symptoms. So this really basically suggests that scar is not a cause of recurrent symptoms, that there may be other reasons, but you can't just assume it's the scar tissue, because statistically it did not correlate with patient outcomes.
We really don't know 100% on that.
Yeah.
Because the scar will pinch nerves. We know that. And a lot of scar is bad news because it presses on the nerves, which are already damaged.
And we know in peripheral nerves that if you go in and do a neurolysis, which is you remove the scar tissue from around the nerve, that you can get a much significant improvement in pain as well as significant in outcomes. I know that my first father-in-law hurt his forearm, and he developed a point where he actually could not flex his hand over about a 2-year period, and went to see many, many doctors. Finally, they found a neurosurgeon who went and did a neurolysis of the nerve in his forearm, and he got full function back and loss of pain. So we do know that scar tissue around a nerve, if it involves the nerve itself, can lead to pain and dysfunction of that nerve.
Oh, there's no question about it.
And neurolysis is a well-recognized surgical technique for improving that.
And all you have to do is make sure you have good visibility with a microscope or loops.
Yeah. And here are just some other examples of scar, post-operative scar in patients. And then here's pre-surgery. We can see a little bit of edema maybe in the nerve root there on the left side. And then and this is decompression surgery. We can see that the nerves.
Well, the scar also will entrap the nerve and not allow it to budge, and then that puts tension on it when you bend or extend, and then the scar just grabs the nerve and yanks on it when you move. So that's just common sense.
Yeah. And if you do diffusion tensor MR imaging of peripheral nerves, if you have significant scar involvement of that nerve, what you'll find is you do not have normal flow of water along the nerve. And if you do a surgical neurolysis, the MR findings of abnormal diffusion get better, and along with the patient's symptoms. So definitely scarring can affect the nerves. So this just shows post-op enhancement here of the scar as well as the nerve, the swollen nerve root. And this is just, I don't know, this is, again, just shows some enhancement of scar. Let me think. Who did the last one?
Me.
You did?
I'm up. I'll take it. 22-year-old man, persistent back pain after surgery. So it looks like there's a sort of large cystic focus communicating maybe with the spinal canal through a laminectomy defect on the right. And yeah, it looks like some sort of meningocele or pseudomeningocele.
So this is, again, I don't see it as much as I used to, but this used to be a fairly common complication of surgery where you get postoperative pseudomeningoceles, and this is all CSF. And I've even had a few cases where these got infected and they developed meningitis. So that's another complication that you have to look for in the postoperative spine. Okay, Thomas, what do you think of this case?
So there's some disc protrusion or extrusion at L4, L5, L5S1, and on T2, T1.
So this is probably pre-contrast on the left. Oh no, this is just one study over, another sagittal image. Okay, and then here are the axial images. I think I already showed this case. That's just a recurrent disc extrusion. So this was gone. So what is the role of MRI in the postoperative follow-up of sciatica? So this was that study in New England Journal of Medicine. So they looked at a number of MR findings. They looked at disc herniation, nerve root compression, herniation size, herniation morphology, and perineural scar 1 year after surgery. And they find that those findings had no correlation with patient outcomes. So I think you're seeing a trend here. A lot of these studies are basically saying that our old assumptions upon what findings are associated with back pain are just probably wrong. And they've led to a lot of surgeries and a lot of other treatment of patients that were either unnecessary or made patients worse. So, especially now disc herniations, as we've talked about, if you have an acute disc herniation, that has the best prognosis, and it's best left alone because they all get better. And there was thought 15 years ago that if you have a disc herniation that compressed the nerve, you had to operate immediately. Otherwise, you'd get irreversible nerve damage, which would lead to chronic pain. And studies following patients with nerve compression have shown that there's no evidence now that that's the case. And actually, the patients with the larger size herniations, there's a kind of a trend for those having the best prognosis in the long term, or not in the long term, at a 1 year follow-up time.
Bed rest for a few days and then progression of activity.
Okay. So here's a patient who had a post-op follow-up. We can see the post-operative changes here. We can see a little protrusion in the disc. The periphery of the protrusion enhances, just showing that you have granulation tissue there. Here we can see some enhancement of the nerve root on the right side and the laminectomy defect, and the extensive atrophy of the spiny erecting muscles. That was a protrusion. Here's a...
I'm sorry, John. 40 or 50 years ago, the treatment for back pain, acute back pain, was bed rest in a hospital.
Yeah,
that lasted 7 to 14 days. And either the patient got better or they wound up in surgery.
Yeah. And then after surgery, you'd have a body cast for months.
And one thing that prevented a lot of surgery in the past was myelography. Anybody that went to have a myelography quite often, I shouldn't say everybody, but quite often, anybody that had myelography was going to have surgery, because myelography is not exactly an innocuous procedure, not from the old days with that dye we used to use. So anyway, that prevented people from having myelograms because the surgeons didn't think they should have surgery. So they put the patient in bed rest and sometimes traction of the pelvis and physical therapy. Unfortunately, therapy was ultrasound for 5 minutes, which didn't do a damn thing. A nice massage heat and heat packs and so on are helpful, but ultrasound I never found to be of any use.
Okay. Oh, this just shows another post-operative protrusion in a patient with surgery. So why don't we stop here, and we'll pick up tomorrow, and we'll go through some more post-operative complications that you need to look for. Fortunately, with modern techniques, a lot of the post-operative complications that we will be talking about are much rarer than they were before. Yeah, I did a lot of monograms in the old days.
That depends on the surgeon.
Yeah.
Well, in the old days, a lot of neurosurgeons wanted to do and did their own myelograms.
Yeah. All right.
Well, have a good evening, everyone. And this was some kind of a